Hello. Welcome to the Cancer Informant. I'm Dr. Tony Malioco. I'm a cancer specialist and I'm the Cancer Informant. Today's talk is going to be focused on breast cancer. This is the second podcast of a two-podcast series dedicated to patients with breast cancer. It's October and it's Breast Cancer Month. Breast cancer is one of the commonest cancers that affects up to 1 in 8 women over the course of their lifetime. Fortunately, breast cancer is eminently beatable and survivable. With early detection and proper treatment, the outcomes are excellent. First, what causes breast cancer? Well, we're not quite sure what causes all types of breast cancer, but there's certain risks for development of breast cancer. One of the strongest risks is inheriting a breast cancer-associated gene from one of your parents. These are genes that are passed on from the parent to the child at the time of embryogenesis. They are often genes that are involved in DNA repair. The most common ones that have been identified are called BRCA1, BRCA2. Now, there are many other genes that are also associated with breast cancer. These are things like CHEK2, RAD53, and others. How do you know if you have an inherited breast cancer gene? Well, one way to know is, first of all, know your family history. Did anyone in your family have breast cancer? Did they have breast cancer at an early age? By an early age, generally we mean under the age of 50. It is quite unusual for a patient to get cancer under the age of 50. So often cancers that develop in younger people are attributable to a damaged gene. Now, these genes are often involved in something called DNA repair. So every time your DNA divides, there's a mechanism inside of cells to edit it and stop cells from dividing again if there are any damage to the DNA. Now, if you happen to inherit a faulty DNA repair system or a faulty DNA damage repair system, DNA damage can accumulate within the cells, and this can lead to the development of a cancer. Cancer is most often caused by damaged DNA. So the damaged DNA can come from environmental damage, exposure to radiation, or to chemical carcinogens. In fact, some infections may also lead to damaged DNA as well, which can lead to cancer. We also know that in women, there are other risk factors for development of breast cancer. These include low parity, meaning have low numbers of children, and also exposure to diabetes is another risk factor. Alcohol exposure is another risk factor. And there may be some risk factors related to exposure to organic solvents and certain pesticides can also lead to the cause of breast cancer. It seems that most breast cancers are driven by hormone drivers, so particularly estrogen. So the amount of time that a woman is exposed to estrogen increases the risk of her developing breast cancer. That means unopposed to progesterone. So the more pregnancies a woman has, the less the overall exposure to estrogen and the reduced rate of getting breast cancer. It's also thought that perhaps oral contraceptive pills may have some protective effect as well. Now, other factors that are a risk factor is something called atypical proliferative breast disease. Now, what this means is if the breast is abnormal, if there are abnormal growths inside of the breast, and these can be detected by mammography. So in mammography, there may be abnormal calcifications. When a pathologist or when a surgeon removes these abnormal areas and a pathologist looks at them and determines that there actually isn't any cancer, but that there is something called an atypical proliferation. We know that these women with these atypical proliferations may have a subsequently increased risk of developing an invasive cancer. So close examination of these types of lesions is very important. The other thing is that abnormal breast proliferations may also lead to atypical calcifications or microcalcifications that are present in breast tissue. These microcalcifications can be visible on mammography and lead to the biopsies that lead to the diagnosis. Breast cancer may also be more likely to occur in women with dense breasts. Now, this can be a problem because dense breasts are not easily visualized using mammography. And this presents a problem in that cancer may be missed in women with dense breasts. To combat this, other technologies are being considered. For example, MRI examination of the breast or other types of imaging of the breast may help uncover breast cancer that is hiding inside of dense breasts. There are also some new tools being developed. These include artificial intelligence, where a computer can look at a mammogram and determine if there's abnormal findings present in the mammogram that a radiologist might not be able to see. The computer may be able to identify these abnormal features and then prompt the radiologist to look at those areas or indicate that there is a cancer in that area that a surgeon can remove. Another risk factor for breast cancer is actually diabetes. And this brings up the understanding about how cancer may be related to diet, which is quite interesting. We know that in North American and westernized countries that the rate of cancer is increasing and that there's a strong link between obesity and diabetes and certain types of cancer. We're not quite sure why this link is there. It could be that in diabetes, there's alterations. This is particularly type 2 diabetes, that there may be alterations in insulin, and insulin is a type of growth factor. Insulin may drive the growth of abnormal cells and lead to the development of a cancer. In addition, the presence of increased glucose or sugar might feed a cancer and cause it to grow and proliferate. So there's a lot of ongoing investigations about whether dietary modifications can adjust the rate of cancer or could actually improve the ability of therapy to treat cancer. So this is a very interesting and productive area. And another area that's somewhat tied to this is something called microbiome or microbiota. You might be surprised to know that the human body has many microorganisms that live in harmony with our body cells. It's estimated there may be as many as 10 trillion microbes that live on us and in us, and that these actually help us, that if our normal bacteria get disturbed, for example, by use of certain kinds of antibiotics, an abnormal or pathogenic bacteria might take its place and cause disease, such as diarrhea and other types of problems. So our normal bacteria actually protect us sometimes from these abnormal bacteria that can cause infections and problems. Now, it appears that the microbiota have a close relationship with the immune system, and that if you have a healthy microbiota, and mostly that's in your colon, where you have many, many different species of bacteria living in your colon, if your colonic microbiota is healthy, then it appears that your immune system is more likely to be healthy. If you have a healthy immune system, you're more likely to suppress cancer. And if you get an early cancer, that your immune system may be able to remove it or keep it under control. So again, we're just really beginning to learn a lot more about how the immune system works and how to keep it healthy. And the work on microbiome is a very important area of investigation, learning about how the microbes interact with the immune system and protect us from cancer. Fascinating work happening there. Another area that's of interest is infectious particles, such as viruses, that interestingly in mice, that breast cancer is inherited through something called an endogenous virus, mouse mammary tumor virus. And this is where the mother mouse carries an infection with the virus that can actually be passed on to the pups. And the pups can develop cancer in the breast as a consequence of being exposed to this virus. Now, in humans, we're really starting to learn about, is cancer driven by viruses? We know that in cats and dogs and other animals that the viruses do drive cancer. And we're also learning that in humans, many cancers are driven by viruses. The ones that are most known are cervical cancer, where we know that human papillomavirus, when it infects the cervix, in a small proportion of women will drive that into becoming malignant. We're not quite sure why this happens, but we do know that if we could prevent the human papillomavirus infection using vaccines or other approaches, that perhaps we could prevent cervical cancer from developing. We also know that there are HPV-driven cancers in men. These include cancers of the head and neck, and also in women. Penile cancers and anal cancer are also driven by the human papillomavirus. So having vaccinations against the human papillomavirus can reduce the rate and risk from those serious cancers. And it's something that there's national vaccination programs underway in an attempt to reduce HPV-associated cancer in the US and globally. We know that other viruses can cause cancer, such as hepatitis B, which can cause liver cancer, and so on. Now, when it comes to breast, we haven't really identified a breast cancer virus that's associated with cancer, although there is some tantalizing work looking at human endogenous viruses. And humans have viruses that are encoded in their DNA that they've inherited through time that are present in the human genome. And some of these may become unleashed by unknown mechanisms that could lead to development of cancer in certain tissues like breast. But this is very theoretical. So these are some of the risk factors for cancer. Now, how might cancer be detected and diagnosed? So first of all, a cancer in a woman's breast may not have any symptoms at all. It may be found on a mammography exam where abnormal lesions or calcifications are found on mammography and where a biopsy leads to the discovery of the cancer. So this is why mammographic screening is important. The downside of mammographic screening, it's far from perfect, and it leads to many false positives and also false negatives. So this means that a lesion may be seen on mammography, but when biopsied, turns out to be benign, or there may be some cancers that are missed by mammography, which is obviously a problem. But mammography is so far the best technology that we have for detecting cancer. There are other screening methods currently under investigation, such as altered types of mammography, ultrasound, thermal imaging, even other kinds of magnetic imaging of breast or electrical imaging. And some groups are working on blood tests that may be able to detect abnormal proteins or abnormal DNA in the blood that may indicate there's an underlying early breast cancer. So a lot of work still needs to be done on screening so that we can get breast cancer at an early stage. We know that the earlier the stage you detect breast cancer, the better the outcomes will be. Now, another way of breast cancer can be detected is by presence of a lump. So a woman may detect an abnormality in her breast, the presence of a hard lump. Now, typically abnormal lumps, which are lumps that are spiculated or star-shaped or are affecting the skin or the nipple, are of great concern. These are the types of lumps that are more likely to be cancer. Often cancers are painless, so they may not have any pain. They're typically hard and irregular and can be palpated. Mobile rubbery lumps are more likely to be benign tumors or cysts within the breast, where benign fluid accumulates in the breast and can present as a rubbery lump. Now, another way a breast cancer might present is an abnormal discharge from the nipple. So if the nipple is discharging blood or abnormal fluid, this can be a sign that there may be a malignancy hiding inside of the breast. and it certainly is cause for concern and further evaluation by a surgeon or a radiologist to determine what is the underlying cause for that. There's also a certain kind of cancer called Paget's disease of the nipple. And in this case, the cancer is growing inside the ducts of the breast, but spreads onto the skin surface and causes a condition that mimics mastitis. And this can be a problem because it can look like an infection, but it's actually a serious underlying cancer. So women who do present with scaling or red lesions of the nipple, it should always be considered, could there be an underlying cancer in that breast? And it's certainly worth closer scrutiny. Now, what happens after a biopsy is done? So typically, if there is one of these abnormalities, either on mammography or a lump, a surgeon or a radiologist will undertake a biopsy. So a biopsy is taken. It can be a core. It's better to do a core rather than an FNA or fine needle aspirate. The biopsy is sent to a pathologist who will examine it and determine what is present. If there is breast cancer present, the pathologist will report back to the surgeon, and additional surgery is typically done. The pathologist will also perform additional evaluations looking at key biomarkers. Now, what is a biomarker? A biomarker is a type of protein or gene that is present inside of a tumor that can help guide therapy. And for breast cancer, the most important ones are estrogen receptor, progesterone receptor, and HER2. So when a pathologist observes the presence of breast cancer, they will automatically order these tests to be done so that the information becomes available to the oncologist and to the surgeon in as quick a time as possible. Now, if the tumor is quite large, let's say it's several centimeters in diameter, often a type of therapy called neoadjuvant therapy is given. Now, in neoadjuvant therapy, endocrine or trastuzumab, an anti-HER2, or a chemotherapy is given to the tumor with the idea of shrinking it to make it more easy to remove. And this often happens to women with large tumors, and there's often dramatic shrinkage of the tumor where the tumor can be easily removed. In some instances, the tumor is completely removed by the therapy, by the neoadjuvant therapy, and no residual cancer is present at all. This can present some difficulty for pathology because if there's no residual cancer at all, then there isn't any tissue left to do the additional tests that are necessary to really help select the therapy and guide therapy for a patient. Following neoadjuvant therapy, the pathologist looks very carefully at the breast to determine what was the amount of response from the neoadjuvant therapy. If there's dramatic response, this is really an excellent and a good sign. And the staging that is done at this point is really critical in determining the next steps of treatment. If neoadjuvant therapy isn't done, typically surgery will be done. So usually there's two options. You can do breast conserving surgery, or you can do a mastectomy. And over the years, surgery has become more and more minimal. Back 50 or 100 years ago, surgery was actually quite dramatic, where often a mastectomy was done and the pectoralis muscle was removed and the chest was opened and internally mammary lymph nodes were removed, and really drastic, serious surgery was done. But over the years, it was determined that actually lumpectomy could be equally effective to more drastic surgery. So this is lumpectomy with radiotherapy. So the combination of lumpectomy with clear margins and radiotherapy is very effective in controlling breast cancer. And usually that's the first approach to treatment in women who have localized disease. So essentially the tumor is removed with clear margins, radiotherapy is planned. In addition, the lymph nodes need to be examined. Now, the lymph nodes are very informative. They can tell us whether the cancer has spread, whether the cells have gone beyond the breast to other locations in the body. Now, in the old days, back when I was younger, they would remove as many lymph nodes as they could. So they'd remove 10, 15, 20 lymph nodes. The pathologist would examine them and determine how many were positive for cancer. Now, one of the problems with removing a lot of lymph nodes can lead to a disturbance of the lymphatic system, which can lead to a problem called lymphedema. And in this case, the arm can swell up and fill up with fluids, and this can be extremely problematic in that lymphedema can cause pain and disturbed motion, all sorts of problems. Now, cleverly, surgeons and oncologists have come up with a better idea where they have learned how to remove just the key nodes, and this is called sentinel node biopsy. In sentinel node biopsy, a small amount of dye or radioactive substance is injected into the tumor, and then auxiliary lymph nodes are examined either to look for color pickup of the ink or by radioactivity. So the surgeon can then pinpoint the first draining node. That's called the sentinel node. That node is removed and examined by a pathologist. If that node is negative, then no further nodes are removed. If that node is positive and contains cancer, then additional lymph nodes are removed to actually determine how many nodes are positive. The number of positive nodes are important as that's part of staging. So if there's less than 3 nodes, that's great. Between 3 and 9, that's more problematic. And if there's 10 or more, that puts it into a later stage, which is, again, of concern in that the later the stage of a cancer, the greater the likelihood that there's metastasis and that cancer will recur after localized treatment. So it's very important to have accurate staging. Now, beyond the lymph nodes, the cancer cells can spread to other organs. So these include the bones, the liver, the brain, and other parts of the body. So often at the time of surgery, an additional staging studies will be done to determine if the bones are free of cancer or if the liver is free of cancer and so on. This may involve a CT scan or may involve a bone scan or a PET scan. These are very special types of radiological procedures that can identify small amounts of metastatic cancer. Now, following the local treatment of cancer, then the choice is that whether adjuvant therapy is needed. Now, typically, breast cancer is classified into really 3 types of breast cancer. There's a type that's estrogen receptor positive, a type that's HER2 positive, and a type that's triple negative. So if the tumor is positive for estrogen receptor, usually endocrine therapy is indicated. So these are treatments that block estrogen receptor and stop the tumor from growing. So if there's any metastatic disease, these are called systemic treatments because localized control is done using surgery and radiotherapy. But if there are any cells that have escaped and gone to other parts of the body, we have to clean those up with systemic treatment. Now, these mets or these cells that have escaped may be so small we don't even know they're there. And that's why we're doing adjuvant therapy with the hope of stopping those cells from growing and turning into metastasis. So the adjuvant therapy typically includes endocrine therapy if the tumor is ER positive. It may involve trastuzumab or an anti-HER2 drug if the tumor is HER2 positive. And if the tumor is triple negative, this can be a little bit more problematic, and that there's different choices for a triple negative tumor, typically chemotherapy. But if the tumor is spread, we might also consider immune therapy or PARP inhibitors. And this brings up the association with inherited cancers, that inherited cancers often present with triple negative disease. They're more likely to occur in African Americans. And if the tumor is triple negative, these tumors are more likely to respond to immune therapy and also to PARP inhibitors. So you can see that the classification of breast cancer is very, very important in picking up the right kind of therapy. Interestingly, there's some new types of therapy against HER2 that are directed against tumors that are HER2 low. So these are breast cancers that have very low levels of HER2 by protein that normally would not be considered for normal anti-HER2 therapy. There's a new supercharged type of anti-HER2 therapy where the trastuzumab antibody has been combined with a toxic poison drug that is topoisomerase 1 or 2 that can block the growth of dividing cells. So in tumors that are HER2 low, this new antibody conjugate can be given. It's called Enhertu or famtrastuzumab that can be given that can really inhibit the growth of these types of HER2-low cancers. These are now approved for women with metastatic disease, and it's actually a real breakthrough. It was very exciting at the last ASCO meeting when the data was unveiled, because the women that have HER2 high are actually only about 15% of breast cancer, so there's only a subgroup of those that exist. But the HER2 low group is actually over half of women who have HER2 low breast cancer. And when they present with metastatic disease, often there were limited options for them. But now that there's this HER2 low approval, we now have a new treatment option that appears to be quite effective, which is really quite exciting, in that it now opens up a new treatment opportunity for many women that have this HER2 low category. Now, the other way to look at whether a tumor is spread is using liquid biopsy. So liquid biopsy is really a blood test. There's two parts to the blood test. We can look at circulating tumor cells, which are living tumor cells that are floating around in the blood, or cell-free DNA. And this is DNA that is leaking out of dying cells inside of the patient's body, leaks into the blood, and we can measure it. So by evaluating these two components of blood, we can actually determine, are there any cells floating around in the breast cancer patient? If there are these cells positive for estrogen receptor or positive for HER2? If they are, this would be able to tell us that we could possibly treat those cells with an anti-HER2 or with an anti-estrogen agent. We can also look at the circulating DNA and determine if there's any targetable events in that circulating DNA. These might include things like something called microsatellite instability or mutations in a gene called PIK3CA. So if these are actionable mutations, an actionable mutation means that there's a drug linked to that mutation. So by doing a blood test, we can determine if that patient has metastatic disease and if the metastatic disease might be treatable with a targeted therapy. The next thing that should happen with women with breast cancer is genetic testing should be considered. Genetic testing is important for several reasons. One is to determine if a woman with breast cancer has inherited a breast cancer-associated gene from her parents. If a patient does have a breast cancer-associated gene, this information can be useful in planning future treatments. One, we could determine if more extensive surgery should be considered. So if a woman is at high risk of breast cancer, she may want to consider doing a bilateral mastectomy rather than a lumpectomy, because there could be significant risk of another cancer developing either in the same breast, at another location in the breast, or in the opposite breast. So knowing if a patient carries one of these cancer genes is important to plan surgery. Secondly, to plan treatment, so that we know that women who do carry a BRCA gene or a breast cancer-associated gene, they may actually be eligible for treatment with a new type of drug called a PARP inhibitor. PARP inhibitors are quite effective, but they only work in women with inherited BRCA mutations or in tumors that have BRCA mutations that have been acquired. So understanding whether a woman has one of these inherited genes is important for that purpose as well. In addition, if a woman carries a high-risk gene, it may put her at risk of other cancers too. For example, a BRCA gene might be associated with increased risk of colon cancer or ovarian cancer. And this is helpful for a patient to know if they should be concerned about development of cancer at other locations in their body and whether they need to have enhanced monitoring or screening to make sure that they can detect those cancers at an earlier stage. In addition, knowing that you have inherited a faulty gene can also help with your family. So perhaps the patient has a sibling, a brother or a sister who also has that gene, so that they could be at increased risk of developing breast cancer in women, or colon cancer, or prostate cancer in men, and even breast cancer in men. So I raised that also men are at risk of developing breast cancer. It's much less common in men, but men can definitely develop breast cancer. When a man develops breast cancer, about half of the time, he's inherited a faulty gene, most often BRCA2. So men who develop breast cancer are very unusual. Actually, about 1% of the rate of women developing it. They most often develop, interestingly, estrogen receptor positive breast cancer. They are often treated very similar to women in that they'll have a mastectomy, a node examination, and then probably treated with anti-hormonals and also with chemotherapy and radiotherapy. So genetics is important for family planning and for treatment planning. I should also point out that not all genetic tests are created the same, that some genetic tests only test a few genes and leave the other genes unexamined. I strongly recommend, if you're going to get a genetic test all of the genes, get a whole exome done, because that information is useful for the rest of your life. That information is available. You'll learn about your cardiac risk, about other genes that might be associated with other cancers, cystic fibrosis, about pharmacogenomics, drugs you may be toxic to, and so on. So if you're going to do a genetic test, do a proper one and get a full examination. Also, insurance generally pays for genetic tests, but they may only pay once in a lifetime for a genetic test. So it's important that you get the full genetic test done when you're using that once in a lifetime test. Also, it's important that you get that information back so that you can use it for future planning, and also understanding your risk of other medical conditions that can be available in that genetic information. Never be afraid to ask for a second opinion, because getting more information about a cancer is very important to appropriately consider all of the options for treatment. The options are really increasing. There are many, many new therapies that have now been approved, and there are actually hundreds of potential clinical trials. So after conventional treatments are exhausted, there are many, many opportunities for clinical trials that can be extremely effective and can give access to very novel, innovative therapies. And most often, there's no charge for participating on a clinical trial. So it can be a very cost-effective way to get access to very, very innovative treatments. So that concludes my talk for today on breast cancer. I hope you enjoyed it and found it to be informative. Thank you for joining the podcast. Please visit our website to listen to other episodes. I'm the Cancer Informant, and I look forward to you joining us for future installments. Also, please leave any comments or suggestions on our website. I look forward to seeing you in the future. Have a wonderful day. Bye-bye.